Good afternoon, everyone. Welcome to Leader in Action series. Today we have the great pleasure to welcome Dr. Irene Agyepong. Irene, welcome.
Thank you.
And Irene share some common thread with her names with me, because in French West Africa you are called Irene, and you know your name is Irene coming from Ghana. And me, I'm Jean Lebel, but I'm so known under Jean Lebel, and I'm the president of IDRC. And it's a pleasure to welcome you today here in Ottawa, where Irene is participating to the Canadian International Health Conference with numbers of actors from Canada, but from around the world. So welcome her.
Thank you.
Irene, we will talk about your career, your distinguished career. We will talk about the research work that you are conducting in Ghana. We will talk of what are the challenges that are lying ahead in public health. But first, tell me, what type of children were you?
Well, we were normal children. We ran Ghana in the 60s. Accra was not as populated as it is now. My memories of childhood are running around and climbing trees and getting very dirty, and nobody complaining about that so long as you did your homework.
Yes, and you must have done your homework because, you know, you study in medicine.
Yes. Well, basically with my parents, if you haven't done your homework, you cannot run. Once you do your homework, you can get as dirty as you like. They don't care.
So you were in a family that was valuing education.
Yes.
And that brought you to choose medicine. But I've read, you know, Lancet did a profile of you earlier in September, and I've read that you were interested in other things. What were these things that you were interested in your childhood or adolescent life?
Well, I think I, as far back as I can remember, which is maybe, you know, about class 6 or so upwards, I kind of wanted to sew. I love fabrics, and I wanted to write, and I wanted to be a doctor. And my mother, who's a very wise woman, she's passed on, she would periodically ask, what do you want to do with your life? And I would say, well, I want to sew, I want to read, and I want to be a doctor, and I can't figure out how to do all of it. And she said, well, it's quite simple. Everybody has to do something for fun. So if you learn how to make your own clothes for fun, that is a good hobby. And then if you've got what it takes to go to medical school, by the time you've done so much education, if you've got what it takes to write, you'll have enough command of language to write. So why don't you aim for medical school? And if you make it, you will be able to write if you have it in you. So
you were winning on every side.
My mother was wise.
Your mother was wise, and you listened, and you became, you know, this medical doctor. You were deployed in central Ghana. That was probably in the 80s?
Yes, in the 80s.
In the 80s, how was the situation then? What have you faced, you know, from medical school towards, you know, the middle of a country like Ghana?
No, in fact, this was the 80s, and we'd just gone in for World Bank structural adjustments about 2 or 3 years before in 1985. Things were really bad. And from the teaching hospital to a district hospital, it was a big jump. I got there and I found, you know, everything was short. You know, there were no gloves. They would wash disposable gloves, dry them out, and reuse them. You know, we were forever short of cannulas. There was only one fig in the maternity ward. Whenever I came back to the teaching hospital in Accra, I'd go around my friends who were still there. Can I have a few cannulas? Can I have a few cannulas? And I'd put it in my bag and carry it back. So when there was an emergency, I'd pull it out of my bag. So there were the good stories. I mean, there was a woman I've never forgotten her. She lived because I had the cannula in my bag. I'd run out of scalpels, but we bought a brand new blade and managed with that. But there were those who died.
Because?
For these very silly reasons. You didn't have a cannula, there was no blood bank. And, you know, sometimes at the end of the day, I would go back to my flat, I would sit down, go over my day, and to be honest with you, I cried a bit because it's like I knew everything to do, I didn't have the tools. And so not to be too lengthy, my aunt was my aunt was a doctor. She was a public health doctor.
Yes.
And she said, why don't you also try public health? You might find some answers there. So I thought, well, let me give it a try. So I still hadn't made up my mind, but I asked to be posted to the district. In those days, it was a district medical officer for a while. And well, over time, I realized, yes, another way I could also try to fight some of these, because some of the women who died have not left me to this day, the preventable ones. It's like I couldn't save you, but I have to remember you and try and make a difference.
So, you have the field experience. You see the harsh condition, the lack of everything. You go back to do your PhD at that time?
If I spent a year or so in the district. In the district? Yeah, I was still debating, do I become an obstetrician? Do I become a pediatrician? Do I do public health? Yeah. But to cut a long story short, the director of medical services, he came to my district and he said, young lady, if you stay in public health, we'll give you a scholarship. Because you can make a difference. Yes. So I got a scholarship to go and study in Liverpool.
Okay. Yeah. So UK, and then you went back to Ghana, Africa, and you start your public health career. And rapidly, you move towards health systems. Why?
It goes back to the stories I told you, because when I was in the hospital, the women who were coming to die, sometimes I didn't understand them. It was like, but why are you coming so late? Sometimes she'd already have ruptured her uterus at home and you are literally running to save her life. And it's like, why are you coming so late? But when I started working in the district, and I was going around communities, then I began to understand, because some of these communities, the roads were so bad. Yeah. We used to joke that if this road gets any worse, you are going to be cut off from Ghana. And there was no public transport. And you'd see emergencies put on the back of a bicycle. And then it all clicked. And I thought, oh my God, sometimes I was being very unfair to these women. It wasn't that they were, excuse me to say, stupid. No. They are just living in a very difficult context. Yeah, so then increasingly I became more and more interested in the system, in making the system work for people. You still need the clinical care to work for them, because once they hit the hospital, I didn't want them to die the way some of the women died for very silly reasons, like there are no cannulas and there's no blood. Yeah. But then there was the bigger system issues that still get them to the hospital, and the bigger system issues that still led to no gloves and no cannula.
Yeah. And one of the angles that I know has been very important in your career is to develop the capacity of West African, for Ghanaian, in Ghana, in other countries. So if you were to look at today's situation, and the progress that has been made, can you illustrate this to me with one example on how over the last 20 years Ghana has made progress despite some of challenges, but a clear example of how these progress were made?
No, I think we have made a lot of progress. One thing is the economy has improved, and it comes to the social determinants of health. In 92, and it was a lot of we had a military government through the 80s, in fact, through the 70s. And in 92, there was a groundswell of let's have multi-party democracy. And finally, the military government opened up to that. And, I have seen there were several things that happened. One was the airwaves were liberated. They allowed the private media in, and some of the stations started doing social issue stories. So then you got stronger and stronger public advocacy. Yeah. And then you also had the fact that the economy started opening up. So it's been a mix of things, but I would say it's better now. And then, because I'm looking at the doctors who are graduating today, and it's like, some have cars before they graduate. I remember I was earning about $200 a month when I left medical school. We had one very ancient car we all shared in the hospital, and we used to call it the cornmeal machine, because the engine was so noisy.
It was making so much noise. You paid a particular attention to women throughout your career. They are still suffering, a huge burden. They are often forgotten, not looked with their particular needs, not empowered, don't have a voice, that are not part of the process. How did you tackle this with your work?
That is a continuing difficult problem, and just from working in rural areas with rural girls, rural women, I still think there's a lot of advocacy needed for female literacy, for role models. In some of the communities I've worked in, sometimes they hadn't seen a woman who's gone all the way to university. So in their ambitions are limited and constrained by the environment. So I think there should be a lot of effort on female literacy, giving economic skills so that she can stand for herself, take care of herself, and access to information. So those are the kind of
the elements, the basic element. And in the field, in the work you're conducting with IDRC support, you're looking at capacity development for specialists, for people that are active in maternal, newborn, and child health. How is it going? Where do you see the big gap? Where do you see the future of this?
We are actually looking at multi-level capacity building, so at all levels, capacity to use your routine data to analyze situation, do advocacy, and also at the higher levels up to, even training people to doctoral level. And for some reason, and for many of the people I end up training are women, and people sometimes say, I said it's not deliberate, they were the best in the bunch, so it's a whole mix of graded things to build the capacity, and also not just the technical capacity, but also the capacity to be an advocate, to understand the political and the social issues, because transformation is not just technical, it's also political and social.
And this is something that I've read in the book that we recently published at IDRC, but you have been one of the authors. It's called Healthy Lives for Vulnerable Women and Children. And in this book, you'll find numbers of stories of work that has been conducted in Africa by African, and that tell the story that, people need to be at the center, that development is important, that the politics behind health system is important, that funding is critical, that having a system approach, not only, one piece, but, stopping the fragmentation, bringing together is important. And of course, given that we are all about knowledge, innovation, and solution at IDRC, the work of Irene and her colleague brings evidence at the forefront for better decision making. Irene, you received in 2016 the Adjei Distinguished Public Service Award for your academic and policy reform contribution in the field of global health system. I think it's well deserved. I think we are quite happy to have people, leader like you, in action, coming to Ottawa, but doing the hardship work in the field. So congratulations, best of luck in your future project, and thank you for having spent a few minutes with us today.
Thank you
very much, Irene.
Thank you.
So for those of you that have been listening to our interview with Irene Agyepong, I'll see you next time. It was Leader in Action. Irene Agyepong from Ghana spent a few minutes with us, and we are looking forward to our next encounter. Thank you very much. Thank you, Irene.
Thank you.